Dr. Longenecker and ask questions at the end of the talk. So welcome to another Tuesday morning of Yale Cardiovascular Grand Rounds. It's a pleasure to have the cardiology faculty, as well as others who are joining us. I know also from the School of Public Health, who's co-sponsoring this Grand Rounds, as well as others who are interested in global cardiovascular health. So thank you so much for joining us. It's an absolute pleasure to have Dr. Chris Longenecker finally here with us, albeit virtually. As we were chatting about earlier, we had hoped to have him here a couple of years ago, but had to postpone things due to the start of the COVID pandemic. Dr. Longenecker graduated medical school from the Ohio State University School of Medicine, completed internal medicine training at UCSF and cardiology fellowship at Case Western. He joined the faculty at the Harrington Heart and Vascular Institute in 2013, and I believe recently moved to the University of Washington, where he's an associate professor of medicine and the inaugural director of the Interdisciplinary Global Cardiovascular Health Program at the University of Washington. Dr. Longenecker really is a leading expert on the cardiovascular complications of HIV infection and has studied quite deeply the effect of chronic inflammation on vascular and structural heart disease in HIV, both here in the US and also in Uganda, where he's partnered with the Uganda Heart Institute and the Joint Clinical Research Center. His work also aims to build cardiovascular disease infrastructure by leveraging HIV/AIDS infrastructure, which really is a crucial entry point for improving cardiovascular disease care, particularly in low-income countries. He's done this with a focus on rheumatic heart disease. Dr. Longenecker's work is supported by multiple NIH and private foundation grants. And today he will talk to us on cardiovascular disease prevention for people living with HIV in the USA and Uganda. What can we learn from each other? So it's a pleasure to have you, Dr. Longenecker, here with us. Thank you.
Well, thank you so much, Dr. Anuma, for that wonderful introduction. And I'm really pleased to be here finally to talk with you. And I hope we have a lot of fun today talking about a topic that I feel obviously very passionate about. As was mentioned, I have studied inflammation and immune activation as mechanisms of cardiovascular disease in people living with HIV. However, today is going to be focused much more on later stage translational science that we're doing now, implementation science. And the topic is cardiovascular disease prevention for people living with HIV in the USA and Uganda. What can we learn from each other? As was mentioned, I am recently became a Husky and director of the Global Cardiovascular Health Program here, a new program here in the Department of Global Health and Division of Cardiology at the University of Washington. If you're interested, you can contact me here down at my Twitter handle or at my email shown there. So I was supposed to give this talk 2 years ago, and the idea for this talk, the topic, actually comes from the presentation I had prepared. And so finally now I'm able to deliver that topic. This was when I was still at university hospitals and Case Western, but obviously COVID put a kibosh on that. And now 2 years later, finally able to be here. So hope we can have a great discussion today. I'll start with talking a little bit about the background of both the epidemiology of HIV, which for some of the cardiovascular disease people in the audience may be less familiar, and talk about cardiovascular risk in people living with HIV. And then move on to talk about an NIH-funded U01 project we're doing here in the United States called Extra CVD, and then move to a clinical trial that we're running in Uganda together with colleagues from Yale called the Palesa Uganda trial. And we'll end with some conclusions about a concept that I'll call reciprocal innovation, which is gaining traction. This idea that we are learning from each other in high income countries. We're learning from what is being innovated in low and middle income countries, and vice versa. So we'll start with a little bit about HIV. HIV is obviously been around for a few decades, but currently affects about 38 million people around the world, according to UNAIDS. And we all know that the vast majority of this disease burden is on the continent of Africa and sub-Saharan Africa in particular, as shown here. But the situation has dramatically improved since I first visited Swaziland in Southern Africa in the year 2003. Now ART coverage has dramatically improved. ART stands for antiretroviral therapy, and such that in many parts of sub-Saharan Africa, patients now have access to the same types of antiretroviral therapy that we have access to here in the United States. And we can describe the HIV/AIDS treatment cascade as follows. There are 38 million people living with HIV, as I said, and 87% of them knew their status in 2020, and 73% are now on ART. And this from the GBD collaborators in 2015 estimated 15 million. That's now up to 27 million. So really pretty incredible, such that 66% are overall virally suppressed. And we'll come back to this concept of the treatment cascade later when we talk about extending the treatment cascade. So you can see that obviously the increase in ART coverage has been greatest in areas where it was poor when I first went to Swaziland in 2003. And in areas of sub-Saharan Africa, but also in areas of Eastern Europe and Asia. This has consequently led to major declines in mortality due to declines primarily in AIDS mortality, and the blue line there is sub-Saharan Africa. And as AIDS mortality has decreased, obviously something has to take its place, and mortality from non-AIDS comorbidity is obviously the most logical, and cardiovascular disease in particular is therefore on the rise. So AIDS is on the decline, cardiovascular disease is on the rise. But is this simply because AIDS mortality is on the decline, or is there something else about HIV that increases the risk of cardiovascular disease? Well, there have been multiple large epidemiologic studies over the years that have associated HIV with a higher risk of coronary disease, as shown here in this slide adapted from Steve Grinspoon from Harvard and MGH. The issue is that most of these studies have been conducted in the United States and Western Europe, Canada, showing about a 1.5 to 2-fold increased risk of disease. But we don't know for sure whether this is true in sub-Saharan Africa. When we think about, however, the population impact of HIV on cardiovascular disease burden, we must take into account not only the risk associated with HIV infection itself, what is that relative risk, but also the prevalence of that risk factor in the population. And that will give us a population impact, which we measure by population attributable risk or population attributable fraction. So in work that we did in collaboration with Anoop Shah from the University of Edinburgh, we estimated the global burden of atherosclerotic cardiovascular disease due to HIV. And as shown here, really, that tracks very closely with the prevalence of HIV, with population attributable fractions reaching 15% in parts of sub-Saharan Africa. So if you look at a country level, which we did in the appendix, in Uganda, where I work, the population attributable fraction of HIV for atherosclerotic cardiovascular disease is about 4%, 5%. Very similar to other countries in East Africa, such as Kenya, Rwanda, but not quite as high as Southern Africa, where the HIV prevalence is much higher. But certainly the population attributable fraction is much higher than in countries where the CVD burden is quite high, like Pakistan and Kazakhstan, yet the HIV prevalence is low. So what accounts for this increased risk of HIV itself, this residual risk? Over the last 20 years, many people have been trying to figure this out. And I would say that at the beginning, there was a lot of thought that the antiretroviral drugs themselves were causing heart disease in people living with HIV, protease inhibitors, and other mitochondrially toxic nucleoside reverse transcriptase inhibitors. But that has changed as ART has evolved and gotten much more metabolically friendly, such that now we appreciate inflammation and immune activation are likely very important contributors to this residual risk that persists despite effective combination antiretroviral therapy. But there's also the possibility that some residual confounding from traditional risk factors, which are more common in our population, could also explain. But when you step back and say, in terms of the total burden of disease, not just that HIV specific part of the disease burden, what is most important is truly the traditional risk factors. And in this very nice study from the North American AIDS cohort collaboration from Carrie Altoff at Hopkins, you can see that the population attributable fraction for myocardial infarction in people living with HIV is much higher for these traditional risk factors, total cholesterol, hypertension, and smoking, than it is for HIV-specific factors such as increased viral load or low CD4 count. And so if we want to really move the needle on preventing cardiovascular disease in the population of people living with HIV here in the United States, we need to focus on these traditional risk factors. And yet we also have seen recently that guideline-directed medical therapy for the prevention of ASCVD is prescribed less often for people living with HIV. As shown here by Joe Ladapo and colleagues, statin use in particular is lower among people living with HIV. And so what can we do about that? In 2019, a group of us participated in a scientific statement from the American Heart Association on the characteristics, prevention, and management of CVD in people living with HIV. And we took this opportunity to point out that there are many opportunities in implementation research to leverage the HIV care cascade and the infrastructure that exists to deliver integrated cardiovascular prevention care. And many different types of ways that we could do this, but we suggested things like strengthening specialist referral pathways, nurse management, co-located clinics. I'll take a moment just to mention, in Cleveland, I ran a cardiovascular disease clinic for people living with HIV, and I'm looking to do the same thing. In fact, start this week at the Madison Clinic here at Harborview Medical Center in Seattle. So these are things that I'm very interested in. Today, we're going to focus initially on the nurse management program that we're developing. This is called a nurse-led intervention to extend the HIV treatment cascade for cardiovascular disease prevention, or extra CVD. But first, before I begin to delve into the specifics of extra CVD, I'd like to take a moment to just go through an exercise that I think you'll find inspiring and sets the context for what we're trying to do. So imagine you have two patients here in your panel living with HIV. We'll call this guy on the left, Greg. He's 50 years old, which is a little younger than the median age of the HIV population here in the US. He's had AIDS for quite a long time, since 2002, and has been on antiretroviral therapy ever since then. And at the time of his initial diagnosis, he had a very low CD4 count of 20, which has now rebounded, is now about 600, not normal, but pretty good. And this guy on the right, we'll call Sam, is also 50, but he's had HIV for not quite as long, since 2010, also been on ART ever since then. But his CD4 count at the time when he was just diagnosed through routine screening wasn't low. It was 600, a little low, now up to 1,000. But what else do we need to know about these patients in order to kind of assess their cardiovascular risk? Well, they both smoke. If you saw those cigarettes there. Like many of our patients, very common in our population. But Greg here on the left has a blood pressure of 140/70 on amlodipine 10 and an LDL cholesterol of 100 on atorvastatin 40. Whereas Sam has normal blood pressure without meds and also an LDL cholesterol of 100 on atorva. So if you were to ask me who has the higher risk here, I think many of you would realize it's this guy, Greg, over here. And that's not only because he has blood pressure issues, still not quite well controlled on amlodipine 10, but also because he had a lower nadir CD4 count and has had HIV for a longer period of time compared to Sam or compared to Bill over here on the right. But here's the kicker. So this guy, Sam in the center, is also 50, but he's HIV negative, also smokes, of course, but he's walking around with a blood pressure of 150/90 and an LDL cholesterol of 160 because he's not in care. He doesn't have a primary care provider because he doesn't think he needs one. And so you can see that the opportunity exists now because we have these HIV patients in care, that we can provide the type of cardiovascular disease prevention care that will actually put them at lower risk than people who are otherwise walking around with untreated risk factors. So let's talk about the HIV treatment cascade. For those of you who are familiar with HIV care, we talk about needing to diagnose a certain proportion of people living with HIV, prescribe antiretroviral therapy, and then have them take that therapy as prescribed in order to achieve suppression of the HIV virus in the blood. And we talk about these goals used to be 90, 90, 90, now 95, 95, 95% in order to achieve the health benefits that can be very dramatic on a population level. So when we achieve these high rates of people in our clinic who have a suppressed HIV viral load, the HIV care actually becomes pretty easy. And these patients are very healthy. And it's at this point that I feel that we need to turn our attention towards the prevention of non-AIDS comorbidity, to extend the HIV treatment cascade for the prevention of atherosclerotic cardiovascular disease, among other non-AIDS comorbidities, by appropriately diagnosing high blood pressure and cholesterol, appropriately managing those conditions, and most importantly, by treating aggressively to reach blood pressure and cholesterol goals. And so this is the extended HIV treatment cascade.
Chris,
so what are the barriers?
Can I ask a question on the previous slide?
Yeah.
So so I was wondering, you have blood pressure and cholesterol as the third goal for ASCVD prevention. And I was wondering if it was intentional that identification and control of type 2 diabetes and high blood sugar was purposely left out, or is it thought to be less of a risk factor than cholesterol? Because I thought it was about on the same order.
Absolutely, Donna. Thank you for that question. What I would say is that for our extra CVD study in particular, we're focused on blood pressure and cholesterol. But I do agree with you that diabetes is an important risk factor, should be managed. We have drugs to do that now that we didn't have access to even a few years ago, that are really powerful in terms of cardiovascular disease risk reduction. But yeah, for extra CVD, I'm talking specifically about blood pressure and cholesterol.
But in terms of a comprehensive program, it probably should include that, right?
It should include that. It should include cancer screening. It should include all sorts of other non-AIDS comorbidity management. Absolutely, absolutely. But there are barriers to doing this, and one of those barriers is this idea of perceived risk. And I can't tell you how many times in my clinic in Cleveland, people would come to me and say, I always thought I'd die of AIDS, so why do I need to worry about cardiovascular disease prevention? They continued to smoke, for example. And this is a problem. We showed when we tried to measure perceived susceptibility to cardiovascular disease, found that it didn't really track at all with actual calculated ASCVD risk score. And so it is an important barrier and not the only one. There's also an issue in HIV clinics of who is actually providing primary care. Now, this is different in different parts of the country, but this publication from our colleagues at Duke, Longenecker, looks at the issue of who's prescribing meds for hypertension and hyperlipidemia. And in the Duke HIV clinics, infectious disease was doing it about a quarter of the time. Other primary care providers, such as internists and family medicine docs, about 17% of the time, trying to do it, both a small percentage, and about 34% of patients didn't have anybody doing anything to manage their hypertension. And hyperlipidemia was worse. About half of the patients really had not had any medicines prescribed for that condition. And looking further at who was controlled, who had a blood pressure less than 140/90, you can see that if infectious disease doc was taking care of you, you had a lower likelihood of being controlled than if a primary care doc, an internist, or family medicine doc was taking care of you. In fact, after trying to control for a number of potential confounders, there was about a 16% lower chance of control if infectious disease was managing your blood pressure. I have a lot of great infectious disease colleagues, and it's not a knock against that. But you have to ask the question, why do people go into HIV medicine? It's not to take care of blood pressure and cholesterol, right? It's to manage opportunistic infections and other sorts of exciting things like that. But it's further complicated by this issue that people living with HIV really, really trust their HIV providers. And this quote from our formative assessment really illustrates that. A person living with HIV, 25 years with HIV, says, "I just have an HIV doc, and he asked me the last time I was in if I had a primary care doctor. And I said, 'That's you.' And he said, 'No, it's not me.' And I said, 'I just have HIV. Nothing else seems to be wrong with me. So you're my primary care doctor until such time as I feel I should see one.'" Very, very illustrative of that significant trust that these patients have for their docs. Another unique issue in the HIV clinic, which is a little bit different than in other primary care clinics, is that there are a lot of resources to help with HIV care. And this graphic, I won't go through in detail, launches some of the policy or describes some of the policy issues that have helped provide HIV care in the United States over the last few decades. And so it is in this context that we derived a strategy to try to improve blood pressure and cholesterol management in 3 HIV clinics in the US. And I'll talk about that in just a second after acknowledging one of our collaborators, Raj Vedanthan, who helped us put together the Extra CVD grant and the idea for Extra CVD. And again, getting at this concept of reciprocal innovation. So some of the ideas for Extra CVD really come from East Africa, from a couple of the projects that Raj has been involved with through the AMPATH Research Foundation in Indiana University, and really a collaboration of universities working in Western Kenya. So this is a collaboration of multiple institutions. As I mentioned, there are 3 centers, HIV clinics, that we're focused on: University Hospitals in Cleveland, Duke Health in North Carolina, and Metro Health in Cleveland. And this is a UO1 grant, so important to mention our collaborators and colleagues at the NHLBI. We're part of a consortium of projects, just as the Palesa project, which we'll get to in a bit. The Extra CVD project was part of the Preclude Consortium, 5 projects that aim to improve heart, lung, and blood disease care among people living with HIV in the United States. And if you're interested in learning more about these other projects, I'd refer you to this publication in Progress in CVD a couple of years ago. So we started by doing a deep dive into a formative assessment of the context in which we were working at these 3 academic medical centers. We performed focus groups and semi-structured interviews among 51 people living with HIV and 34 healthcare providers. And the overall question was really, what are the constraints on and opportunities for integrated cardiovascular disease prevention care for people living with HIV? So I've mentioned some of them already, but I'll just point out a couple of the other facilitators and barriers that we identified through this work. For example, our patients living with HIV are really in tune to the idea of self-monitoring. They're kind of conditioned to know their numbers, their CD4 count, their viral load. So conditioning them to know their blood pressure or their cholesterol, non-HDL cholesterol, was a little bit easier than maybe some patients. We talked about this idea of HIV providers as trusted sources of medical advice, but there are important barriers as well, some of which I mentioned, but also this concept that with all this wealth of resources, so many social workers and dietitian and all sorts of other people trying to see the patients at the same time in clinic, sometimes the clinic got a little busy and there were bottlenecks. There were other issues as well. HIV provider messaging on CVD risk is another example. And then one that I thought was particularly interesting is the concept of differential adherence to antiretroviral therapy versus their cardiovascular disease prevention drugs. For those of you who remember the 1990s, the early days of antiretroviral therapy were literally taking a cocktail of meds. It was called the cocktail for a reason. And now things have improved such that it's one pill once a day for HIV. And when you start to talk to patients about then adding more and more new meds, well, you need a statin, you need an ACE inhibitor and a diuretic for your blood pressure, you need all sorts of other new medications. They start to have PTSD about the days when they were taking so many meds. And some of them selectively say, I'm going to focus on my HIV and then I'm going to stop taking my statin drug. And so this issue was explored further in a paper we published, again, from this formative work. And then finally, I'll mention, besides the whole issue of Ryan White, which we can talk more about if you're interested, there were other influences of the healthcare system on HIV care. And if you think about an HIV provider, they're there to provide HIV care, not necessarily to do blood pressure and cholesterol management. And they're, in some systems, motivated to generate RVUs by seeing more patients for HIV and not to do blood pressure and cholesterol management. And so that was an interesting concept that came out at a few of our centers. So we used all this formative data then to enter a phase in which we'll call the design phase, and using a human-centered design approach, crafted or adapted the ideas that we had for the extra CVD intervention. And this work was led by Angela Afa at NYU, a colleague of Raj Vedanthan's, and a diversity supplement awardee on our grant. She took us through a 5-step process of ideating and conceptualizing and creating, and then pilot testing our intervention, coming back again, measuring feasibility and acceptability, and iterating again to get eventually a final product. Very fun and engaging process that involved many sticky notes, as many of you who have done this before can attest. This is the intervention, or the package of components that we ended up with. Nurse-led care coordination, again, very important when you're not quite sure if it's infectious disease or primary care that's dealing with the blood pressure and cholesterol. Nurse-managed medication protocols to make things straightforward and evidence-based. Home blood pressure monitoring to help patients self-monitor their blood pressure, and electronic medical record support tools. We're testing this intervention in a randomized clinical trial of 300 participants, people living with HIV on ART with a suppressed viral load, who have both hypertension and hyperlipidemia. They are stratified by clinic site and randomized 1-to-1 to receive a prevention nurse intervention, which I just described, versus just coming in for generic wellness prevention education at 0, 4, 8, and 12 months. The primary outcome is a change in systolic blood pressure over that time period, and a secondary effectiveness outcome is change in non-HDL cholesterol. Now, this is a type 1 hybrid trial, so there are some implementation outcomes that we're also interested in. And using a RE-AIM framework, we can think about some of those implementation outcomes. For example, the percentage of patients who ultimately agreed to participate is going to be important. Think about scaling this up and thinking about populations for whom this might not work well. Looking at measures of adoption, such as the number of days where they actually take a home blood pressure measurement, and other measures of implementation, and also some qualitative measures of maintenance as well. One of the process evaluation measures we're particularly interested in is this concept of provider trust and communication, again, which I've mentioned previously. And so we are administering a survey of trust and communication ties and using an egocentric social network analysis approach, looking at how these trust and communication ties may change over time, whether the balance of ties between the HIV providers and non-HIV providers might change as a result of inserting the prevention nurse into the care team. So we have just completed enrollment, and really happy to say that despite COVID, we were able to enroll the target, eventually 298 participants in this trial. And as you can see, what's interesting is we had a number of participants we were able to enroll before COVID, who participated in the trial during the early COVID times, as well as in the later COVID times. And so we were really poised to ask some interesting questions about whether the pandemic has affected CVD prevention behaviors in our population. And so we applied for and received a supplement from NHLBI to do this work, which is called AIM-HI, the long name shown there. And we were interested in what are the intrapersonal, interpersonal, and community factors related to the pandemic that may influence CVD prevention behavior. So things like stress and loneliness, social isolation and emotional support within the network of interpersonal connections, and then the community issues such as healthcare financing, things like telemedicine and that sort of thing. So after this initial impact assessment, which was a mixed methods approach, we entered again another iterative human-centered design phase in which we created then, with the engagement of our stakeholders, a virtual intervention, which we are testing in another arm of the trial of 75 patients who are participating in a virtual only version of this extra CVD intervention. Some of these patients are actually patients who were participants in extra CVD and then rolled into the AIM-HI arm in order to see if it would be an effective way to maintain their blood pressure and cholesterol care after extra CVD. So we just fully enrolled in both of these, and we'll be following those last patients through the end of the year. And so we don't have any results yet, but stay tuned. I look forward to presenting those results sometime next year. So with that, we'll move on now to Uganda and talk about what is different in sub-Saharan Africa. And here's where I get to acknowledge the Yale connection, and in particular, Jeremy Schwartz, who's on the call, and of course, Donna, and all the great work that Jeremy, that you've been doing in Uganda through the Uganda Initiative for the Integrated Management of Non-Communicable Diseases. And Donna, it's really been a pleasure working with you on the biostatistics and analysis design aspects of our study. So some of the background for doing integrated hypertension HIV care in Uganda is a study that was led by Jeremy and his colleagues in Uganda. Martin Mudu here, the first author, really a fabulous young trainee who's on our project. Looking at the hypertension care cascade and together with the HIV care cascade in 3 PEPFAR clinics in Eastern Uganda in 2014 to 2017. And you can see that just as in HIV infection, one of the main issues is trying to keep patients retained in care. But once retained in care, there were still a number of patients who could not get hypertension control. And so they looked at this further and found that there was actually a fair amount of heterogeneity across these 3 different clinics. At one site, they were doing actually quite well, and at 2 other sites, not well at all, as you can see here. And so using a qualitative approach to trying to understand these reasons for the differences between the high-performing and the low-performing sites, they used a CFIR framework to try to look at some of those things and identified 6 of the CFIR components that were particularly important, shown here with purple stars. If you're interested in learning a little bit more about the details of these things, you can reference this implementation science communication paper from 2020. But this is some interesting work that then informed a pilot study of HIV hypertension care integration at the Malago ISS clinic, which is the largest HIV clinic in Uganda. And you can see that at the beginning of their pilot, their hypertension cascade at the clinic was actually quite poor. And in work that was just recently published, over 6 months, they were able to dramatically improve the percentages of patients with hypertension control. This is the pilot data that we used to then apply for more funding to see if this might be be able to replicate it at a little bit larger level in the Kampala and Wakiso districts, which is the POLESA study, as shown here with our logo. So POLESA Uganda takes a form that is very similar to what I just presented for extra CVD. In aim 1, we had a formative aim where we explored the practice routines, barriers, and facilitators of evidence-based blood pressure care in these clinics. And then through a human-centered design approach, again, led by Angela Afa from NYU, we began in October of this past year to start to develop this multi-component implementation strategy that we're calling Hypertension Plus to improve uptake and adherence to these evidence-based treatments. We're going to be testing this Hypertension Plus strategy against a hypertension basic strategy, which I'll get at in just a second, in a stepped wedge randomized, cluster randomized trial, which I'll describe in just a bit. And then in an aim 3, looking at the economic and financial sustainability of these different integrated care strategies. A very exciting collaboration led by the contact PI, Fred Simatala at IDRC. Very much an honor to help lead that study as the multi-PI together with Fred and other colleagues at Yale, but also RTI International, the Uganda Heart Institute, and importantly, the Uganda Ministry of Health. So the formative assessment in this case is focused on principles of hypertension care, things like blood pressure measurement, but also current practices of blood pressure management and monitoring, as well as thinking about what HIV care innovations might be used to then create an innovative approach to integrating care using a human-centered design approach. This is our design team from our meeting in October. It was really fun to engage this diverse group of stakeholders, which included not only people living with HIV, but their providers in these clinics in Kampala and Wakiso, as well as members of the investigative team. The process was very similar to the extra CVD process, a bunch of sticky notes, and really getting at this idea in human-centered design that we need to empathize not only with the patients who will be getting care within this new strategy of trying to integrate hypertension care and HIV care, but also the providers who are trying to provide that integrated care. And then designing a strategy which will address both providers and patients. So the two implementation strategies that we're testing are what we'll call hypertension basic, which is simply just to provide access to medicines that many patients don't have because the supply chain in Uganda, at least, is broken and does not work very well for most patients. But also access to BP machines that actually are functional, that have batteries when they need them, that are properly calibrated, for example. So by removing these two barriers, how much can we actually improve the hypertension treatment cascade? But then the hypertension plus strategy is to layer on top of that a number of additional components as shown here to provide feedback and incentives, an e-consultation referral system, remote patient monitoring, perhaps a limited scope of home blood pressure monitoring, and other sorts of system strengthening and human resource strengthening components. And so we'll be testing these two strategies in a step wedge clinical trial that Donna has been very integral in helping us to design, the final iteration of which is still to be determined, but very near completion. We're interested in the effect of these two strategies on a primary outcome of the proportion of patients who have controlled blood pressure, is defined as 140/90. And we will take the opportunity at a couple different points within the trial to adapt the components of the hypertension plus strategy based on what seems to be working, using a technique and strategy pioneered by Donna called Learn As You Go, or LAGO. And so very excited to get that started, which will be in the fall of this year. We're also, as I mentioned, looking at cost effectiveness as an important determinant of what might ultimately be scalable in low income setting. And so the primary outcomes of our cost effectiveness are really incremental cost per blood pressure controlled patient, but also household out-of-pocket costs as a measure of equity. And so we have an out-of-pocket cost tool that has been developed that we'll be using and thinking about, if patients don't have to go to two different providers, two different appointments, if they can get their hypertension and HIV care in one place, that may certainly decrease the amount of transportation costs that they have to pay for, the amount of lost wages, et cetera. And there are a number of other outcomes that we're looking at as well. And so in conclusion, I'd like to make a few closing comments, and then there should be some time here for questions about this idea of reciprocal innovation that I mentioned. It kind of gained traction initially as using the term reverse innovation, which is the concept of bringing healthcare solutions to the US from low and middle income countries, as shown here in this publication from 2013. But recently, the term reciprocal innovation has been used to say that really this is a process that is cyclical, and to imply that innovation always flows in one direction is not appropriate. And so we are really interested in whether or not some of these ideas that, as I mentioned, Raj Vedanthan was honing in East Africa could be applicable to the US context, and whether some of the ideas in extra CVD might actually end up working in the Palesa strategy as well. There are several examples of reciprocal innovation in healthcare, as shown here. Companies like GE that developed low-cost ECG machines in India and then are now in use in the United States, or groups like Partners in Health, who pioneered close-to-client care in Haiti and are now using similar models in Boston to improve care in the US. So I think there are plenty of opportunities to learn from each other in terms of improving cardiovascular disease prevention care for people living with HIV. Some of those lessons are shown here as compiled by Raj, and I won't go into detail. Some of them I've mentioned, and we can talk more if people are interested. So in conclusion, strategies to improve cardiovascular outcomes for people living with HIV. should seek to first thoroughly understand the context of CVD prevention care in HIV clinics, both in the US and abroad, to then engage stakeholders, and most importantly, people living with HIV, in innovative ways to develop and test strategies to improve uptake of those proven and effective prevention measures. And then thirdly, to take advantage of massive investments in and lessons learned from HIV care in sub-Saharan Africa and other LMICs to reciprocally innovate solutions across LMIC and high-income countries. And so with that, I'd like to thank a huge number of people who have been involved in both of these efforts, as well as funding and study participants. Really been a pleasure working with all of these different people during this work. And with that, I'll end and take any questions.
Chris, thank you so much. That was absolutely excellent. And it's just so wonderful to hear of all the work that you're doing and sort of, the cross links between the work here and what you're doing in Uganda. We have a couple of comments, and I encourage everyone either to do a hand raise if you'd like to ask a question, or just put a question in the chat. We already have a couple of, one question and one comment. So I'll ask Jeremy if you want to unmute and make a comment, and Marco Gomez to go afterwards.
Oh, thanks, Oyeri. Hi, Chris. Great job. It was a wonderful talk. I was simply pointing out to you, but also to the Yale audience, just recognition of the Yale Primary Care Residency Training Program that for many years now has had an HIV training track that's training, a couple of residents per year to be able to provide not only comprehensive primary care, but also comprehensive HIV care. I think this sort of addresses, one of the tensions that you raised earlier on in your talk. So I just wanted to recognize that.
Thanks, Jeremy. Yeah, I appreciate that. Love to learn a little bit more about that program.
Excellent. Marco Gomez?
My question pretty much is in regards to, is there a point where we should actually engage patients in cardiovascular disease interventions? For example, when patients start treatment or in the middle, and how does that make a difference in the outcomes of treatment and also in patient health in the long term?
Excellent question. It allows me to take the opportunity to say that the most important thing that you can do for HIV, if you're a person living with HIV, to prevent cardiovascular disease, is to take antiretroviral therapy. And the initial starting of antiretroviral therapy, as everyone knows, it's important to do as soon as someone is diagnosed. And getting them onto treatment is the best thing that they can do for their cardiovascular disease prevention. But soon thereafter, I think if they can take their HIV drugs as prescribed and achieve viral suppression, then I think that's when you start to just start with the low-hanging fruit. Smoking cessation is not easy, but we try to start there, and cholesterol and blood pressure. But things like diabetes management, other sorts of prevention things for other non-AIDS comorbidities besides cardiovascular disease can also be initiated once someone achieves viral suppression. I think if you're dealing with someone who cannot even take their antiretroviral therapy, who has struggles with adherence, I think you have to back off and really focus on the HIV. It really has to be the focus of, antiretroviral therapy needs to be the focus. Does that answer your question?
Yes, thank you.
Hi, Chris. I'm going to take a chance to ask a question here. So, I think that this work in terms of, pushing the CVD care cascade, particularly, in low-income countries in sub-Saharan Africa, is absolutely the way to go using the HIV infrastructure. I'm going to push you a bit to maybe comment on how we extend this work. As you mentioned in the little vignettes that you gave, it's one thing to have people who are in care because they have HIV, but there's also an incredible world of people out there in Uganda and lots of other places who have significant cardiovascular risk factors, do not have HIV, and do not have any access to care. So I guess my question is, how do you think we can start, to think in that Venn diagram of people with cardiovascular disease and risk factors, but without HIV, but keeping in mind the lessons for chronic disease care that we've all learned from HIV care, particularly in low-income countries or resource-limited settings?
Yeah, very, very important question. I think I'd just like to acknowledge the AMPATH folks in Western Kenya that have thought a lot about this and are really trying to do this on a large scale there. I think for us in Uganda, one of the ways that we tried to think about this was for the care of patients and people living with rheumatic heart disease, people who did not have HIV, but had a chronic disease that needed, regular treatment with benzathine penicillin injections. And so we created a network of BPG clinics and rheumatic heart disease clinics that we rolled out using the infrastructure of the Joint Clinical Research Center, which is an HIV care provider. So trying to use that infrastructure to build out a cardiovascular disease care program. We started with rheumatic heart disease, and in many of the regions of Uganda where we went, the care for other sorts of conditions, dilated cardiomyopathy, other sort of heart failure conditions, was improved by access to echocardiography and ECG and that sort of thing. So I think that, I don't know if it's the best answer to your question, I don't have a silver bullet, but I think that slowly we can chip away at improving that cardiovascular disease care infrastructure in a country like Uganda and other low-income countries in Africa. Ultimately, we don't want a parallel system of care, right? We want this to be integrated into the care that the Ministry of Health is providing. And so trying to creep back towards integrating with the primary care infrastructure is also an important thing. And we're trying to explore that with rheumatic heart disease through new grants that are being submitted now, actually.
Excellent. Thank you so much, Chris. Dr. Velasquez, you had a comment?
Yeah, I have to now read my question. Yeah, Chris, wonderful work. It's wonderful to see how this is developed with a cadre of amazing folks like yourself over the last 15 years, and exciting to see all this laid out. I guess my question relates to, as we are doing more and more of these implementation science programs, some funded by the NIH, some funded by other agencies, how do you, in your work, develop relationships with public health officials to start having that those organizations measure the population impact and kind of, I guess, lead to maybe broader support beyond research support?
Excellent. Excellent question. I think it's a long game, and it's all about establishing relationships that go over decades. So I would like to acknowledge, I was at Case Western. They have been working in Uganda for, since the very early days of the AIDS epidemic. And it was through those long-term relationships that we eventually were able to partner with the Ministry of Health, partly because some of the people within the Ministry of Health, one of the former ministers of health, was trained at Case Western, right? It's through those very long-term relationships that we're able to build up kind of very high-level impact over time. I'd like to acknowledge Jeremy and the work that he does to engage the Ministry of Health, and I think has borne fruit. There is now initiatives to get blood pressure meds on the essential meds list that would not be possible without the ongoing work of these research implementation science projects that we're doing. So it's difficult to measure, admittedly, but it's I think only through those long-term relationships that you can have impact. And we do have a co-investigator on PALESA who's from the Ministry of Health, Gerald Matunji, the NCD commissioner. But thank you for that question.
Excellent. We'll take one more question from Dr.
I see Donna has her hand up.
Yeah,
I just thought if there was anybody else, we should let them have a turn because I'm going to get to speak to Chris later. Is there anyone else?
I think the floor is yours.
So, Oyere, I just completely agree with you about what you brought up. And I think that's like the, most important sort of global health question of the current time, which is how can we integrate health services into a single system when what's happened in a lot of low and even middle income countries is that various types of services have been set up in a very kind of verticalized way. And how I see it, and I think this is something that requires a lot of discussion and analysis, is to some extent it's because by the NIH in the United States, because research is driven by disease focused institutes. So if you want to get funding to do HIV, you go to NIAID. If you want to get funding for cardiovascular disease, you go to NHLBI. If you want to address diabetes, you go to NIDDK. If you want to address cancer, you go to NCI. And it's virtually impossible to get funding across the institutes, and then the institutes, feel they have limited budgets. So why would NIAID pay for cardiovascular disease research when we have NHLBI? And it's created this kind of vicious cycle, I think, on the ground. I'm sure that's not the only reason, but say from a US point of view and as a researcher based here, I kind of see it that way. And unfortunately, we don't have our advocate supreme, I don't think, on this call, Greg Gonsalves, but it might require patient advocacy and, extra scientific and extra clinical types of activities and actions to kind of address this verticalized system that we have here. I mean, we've recently had this experience. We have a big domestically focused HIV center here at Yale CIRA. And when we came up for renewal of, a project that was supporting ending the AIDS epidemic projects around the country, we proposed integration of care and bringing in cardiovascular disease into it. And, basically this is funded a consortium by NIAID, NIDA, and NIMH. And they said you can integrate mental health, drug substance abuse, and HIV, but you can't go to chronic disease. So that's the situation we're in.
Yeah, thank you, Donna, for that comment. I do think that the role of the NIH is to spur research and innovation, and then when we think about kind of larger scale implementation, partners like PEPFAR, the CDC, USAID are obviously very important, and they're moving in that direction. And I think it is slow, but I think progress is being made. Maybe if there's a minute, and I see Cheryl Boyce is on the call. Cheryl, do you want to respond? Maybe she's not in a position to respond, but I do think that that the research that we do needs to ultimately inform the other larger efforts through PEPFAR and other organizations as well.
Yeah, I don't know if PEPFAR has changed. I'm not that involved right now, but when I had been, PEPFAR, first of all, had a ban against research at all, and then was getting laser focused on HIV care, like at least under Ambassador Birx. She was really worried about mission creep and was trying to laser focus things back to HIV/AIDS exclusively.
Chris, I know we're right at the top of the hour, but I'd really just want to thank you again for an excellent talk, for spending the early morning with us, and look forward to hearing from you, working with you again in future, and hopefully having you here in person in the not too distant future. But thank you again, and thanks to everyone. See you again next week, Tuesday at 8.
Thank you so much. It was really a pleasure. Thank you so much for the invitation.
Thanks.